So over the next little while, I'm just going to talk very briefly about the morbidity and mortality associated with eclampsia, a very quick talk about the complexity and the pathophysiology, and then what I really want to talk about is a review of international best practice and our national guideline, and then a review of what's coming next. So as I think everyone in the room will know, eclampsia is defined as seizure activity which is unrelated to any other cerebral condition or cause in a pregnant woman who has preeclampsia. There is a fundamental problem with the definition in that many women who actually seize, that's their first presentation of preeclampsia. And the diagnosis of preeclampsia is often made post hoc. There's lots of ambiguity about the derivative of the word. It's definitely known to be Greek, and the literal meaning of the word means shine forth or flashing lights. And it became known as eclampsia because of the well-known clinical sign and symptom that women complain of when they have complicated neurology and they experience flashing lights or spots before their eyes. So that phrase has been in use for about 400 or 500 years now. Although eclampsia as a condition was actually well described in the time of Hippocrates, and there are in fact ancient Egyptian hieroglyphics that depict women with eclamptic seizures. So this condition has been recognized really for a very long time. This graph is from the 50th anniversary of the confidential inquiries, which was published back at the start of this millennium. It's the 50th anniversary, and there were several graphs like this. This is the mortality rate this is the incidence and mortality rate from eclampsia and preeclampsia over that 50-year period. And you can see a big drop-off between 1952 and really the late 70s, which corresponds with increasing caesarean section rates, women coming in because of the NHS coming out of the community and into obstetric units to deliver, and then really static rates for the last few years. And in fact, that's actually mirrored by what's happened in the last two confidential inquiries in which the death rate has remained static. Of the maternal deaths that occurred in 2010, hypertensive disorders of pregnancy accounted for nearly 18% of them. And although accurate figures are difficult to come by because obviously most women who die of preeclampsia and eclampsia do so in sub-Saharan Africa where data is not reliable, the WHO estimate that somewhere between 62 and 77,000 deaths a year occur as a direct result of preeclampsia. Eclampsia, seizure activity, complicates 0.28% of pregnancies in low-resource settings. And that's compared with a very low rate of 2.7 cases per 10,000 maternities in the UK. So you can see that the incidence of eclampsia is much more common in low-resource settings. We know from the severe maternal morbidity report published by MPEC that our figures are actually compare very favourably with the UK data. In this report, we had an incidence of eclampsia of 0.2 per 1,000 maternities. So there were just 12 cases in the report, and that compares very favourably with the UK figures from 2005 of 0.27 per 1,000 maternities. What causes eclampsia? Well, we really don't know. And having spent the best part of 15 years researching all aspects of the pathophysiology of preeclampsia, we really would defy anyone to come up with a very robust, concrete hypothesis that doesn't at least have a few holes in it. We know that cerebral vasoconstriction and vasospasm are actually integral to the development of the disease process. And it's a very neat but not particularly comprehensive hypothesis that isolated cerebral vasoconstriction causes isolated hypoxia and seizure activity. In fact, that's far too simplistic, and advanced imaging studies of the brain during seizure activity suggest that that's not actually the case, because actually cerebral hyperperfusion is actually what's seen during seizure activity. Certainly women who have very significant fulminating preeclampsia develop an encephalopathy related to cerebral edema. They have a hypertensive encephalopathy with small minor breaches of the blood-brain barrier, and that may be one of the causes. Local small subclinical infarction has also been implicated. Cerebral hemorrhage is definitely linked with eclampsia, and in fact eclampsia increases the risk of cerebral hemorrhage significantly. But many women who actually die of eclampsia or die of complications of preeclampsia having had eclampsia don't actually have any evidence of macroscopic cerebral hemorrhage on post-mortem, so that's certainly not a unifying hypothesis. And we all know that many women who have fulminating preeclampsia often have a significant amount of metabolic derangements. So it could be any or all or some, but certainly the pathophysiology is far from completely understood. So I was given a remit to talk about early detection. Unfortunately, early detection of eclampsia is almost impossible. Many women present with fulminating disease with the most vague of signs and symptoms. And there's a variety of studies here, all within the last 15 or so years, which talk about the varying presentation in cohorts of women who have eclampsia. The largest study, the Douglas and Redmond study in the UK, which had 325 cases of eclampsia, showed that headache and visual disturbances were only present in 50 and 19% of patients overall. Headache is thought to be, the number one classical sign of impending eclampsia, and yet it was absent in half the cases. Right upper quadrant pain, or epigastric pain, which is normally associated with fulminating disease and possibly HELLP syndrome, was present in as many women as those who had visual changes. So it's really far from a disease that has a classical presentation. Although the most common prodromal neurological symptom is symptom is neurological, it's actually independent of the degree of hypertension. Women can and do seize in the absence of any significant hypertension, and in fact in the absence of any significant proteinuria, and they're the two defining features of preeclampsia, which is why eclampsia is often the first presenting sign of the underlying syndrome. This data, which is actually slightly more recent, suggests that headaches are actually present on a retrospective analysis in about 80% of women, but these are women who were asked post hoc, did you have a headache before you seized? And many women will know, as many doctors will know, that women do have retrograde amnesia, and really after seizure, their recall is quite poor. But still, you can see here that up to a fifth of women who had an eclamptic convulsion reported absolutely no neurological symptoms before the seizure, which makes the early detection almost impossible. When does eclampsia occur? The Lady Sybil case from Downton Abbey illustrates perfectly that eclampsia frequently occurs in the postpartum period when our index of suspicion is actually low, and when we anticipate that women will actually be on the mend, because we're all taught from the very first day on the obstetric unit as medical students that the cure for preeclampsia is delivery. Once a patient is delivered, she will get better. Well, that is technically true in the medium term, but in the short term, these women remain at significant risk of significant morbidity, and eclampsia is something that frequently presents in the postnatal period. And again, in the Douglas and Redmond cohort, 383 cases, almost half of the cases of eclampsia occurred in the postnatal period, when index of suspicions were low and women were frequently actually on the postnatal ward. And similar figures have been described in other studies. What's the mortality rate? Well, again, figures on mortality are difficult to come by in areas where eclampsia is the most common, but most estimates from the WHO are in the 1% region, sorry, in the 15% region. So if you experience eclampsia in a low-resource setting and in the absence of ready access to any medication or drugs, mortality rates are as high as 15%. In resource-appropriate settings like the UK and Ireland, maternal mortality it hovers around 1%. Although, again, getting accurate figures are difficult because eclampsia frequently occurs in the presence of other complications of preeclampsia, such as HELLP syndrome and obstetric hemorrhage. So tweezing out which is responsible for mortality is difficult. Nevertheless, we know that the number one cause or mode of death in women who experience fulminating disease is cerebral hemorrhage, and cerebral hemorrhage is frequently a complication of eclampsia, or certainly the incidence of cerebral hemorrhage goes rockets if a woman has a fit. But mortality, as we all know, is the tip of that iceberg. And the UK eclampsia population study, published by Marion Knight in 2005, which is probably one of the most comprehensive modern-day surveys of eclampsia, reveal that the perinatal mortality rate for babies that were still in utero at the time of convulsions was nearly 6%. So if a woman seizes and is still undelivered, the baby has a 1 in 17 chance thereabouts of dying, either being stillborn or dying in the first few hours of age. The long-term maternal consequences of preeclampsia, if a woman isn't adversely affected by cerebral hemorrhage and stroke, are actually very poorly quantified. We still don't have any good long-term data on cohorts of women with eclampsia. We do have emerging very good data sets on women who've had preeclampsia, and in particular the Scandinavian data sets are very insightful. They've had a lot of publicity recently, and many people will be aware that they have demonstrated that women who have preeclampsia have a 6 to 10-fold incidence of developing renal failure within 10 to 15 years of the index pregnancy, and an 8 to 10-fold chance of developing chronic hypertension, type 2 diabetes, and a variety of other non-communicable diseases. So this is a disease that actually has a legacy, a long-lasting legacy, for long after the women leave the maternity services. What do we know about standards of care? Well, depressingly, confidential inquiry after confidential inquiry has revealed that death rates have remained almost unchanged over the last 2 or 3 reports. In the last report, in the last confidential inquiry, there were 22 deaths. There were actually 19 deaths of preeclampsia and 3 from acute fatty liver of pregnancy, and they were bunched together because of similar etiological pathways. Of those 22 women, 9 died due to intracranial hemorrhage. That was the single commonest cause or mode of death in women who had preeclampsia, who died of preeclampsia. And the assessors have repeatedly flagged the fact that intracranial hemorrhage is directly related to uncontrolled systolic blood pressure. And it's been a take-home message of two subsequent reports now that we are very, very bad at controlling systolic blood pressure. But you can see that also mortality rates, eclampsia is a significant risk factor for mortality. 5 women died post-seizure, and 3 from cardiac arrest post-fit, and 2 from unknown cause. So there's a significant, having an eclamptic convulsion significantly increases your mortality risk if you have fulminating disease. And again, rather depressingly, in 20 of the 22 cases there was substandard care, and in 14 cases the assessors judged that that substandard care was major, which meant that there were undoubtedly avoidable deaths in that cohort of 22 women. And this isn't news, this is something that we see repeatedly in inquiry after inquiry, but it's something that I think this is what we're really talking about today, and that's the purpose of days like this and initiatives like this. It's beholden to us all to try and get, if not these numbers down, then the numbers of women who are dying because of substandard care to an acceptable level. And I would argue that an acceptable level in the 21st century is probably 0. Resource-appropriate settings are not the only environment in which we see substandard care, though. Not surprisingly, the WHO multi-country survey on maternal newborn health, which surveyed over nearly 400 healthcare facilities in a variety of countries throughout Africa and Asia, showed that near misses were 8 times more frequent in women with preeclampsia, but increased up to 60 times in women with eclampsia when compared with, to women without either condition. So, how do we manage preeclampsia? Well, there's a variety of very good materials available for our disposal, but again, the remit today was to concentrate on local data. We do have the National Institute for Health and Clinical Excellence, the NICE guideline, which has actually superseded the RCOG Green Top guideline on the management of hypertension in pregnancy. This was revised in January 2011 and is still very current. We've got the American College guideline on hypertension in pregnancy, which was published just last year, rising death rates from preeclampsia and eclampsia in America, probably reflecting the increased trend of obesity in the antenatal population, prompted the American College to set up a task force to address rising death rates from this condition. And the guideline was published as a direct reflection of their findings and observations. The Canadian guideline is probably one of the most comprehensive. This is a very large guideline. If no one's read it, I do encourage you to look at it. It's slightly dated now. It was published in 2008 and is currently being revised by Peter von Dadelson and Laura McGee. But it's a very comprehensive guideline which actually doesn't just talk about management in the acute setting, but also talks about the diagnosis and evaluation and management of hypertension in the community and in the daycare unit setting. And it's an extremely comprehensive and very well-researched guideline. And then we have our own guideline, which was published in 2011 and which is currently being revised. So we are revising this at the current time and would welcome anyone's feedback or thoughts on the first version. So what's common to all these guidelines? Our guideline draws heavily from the NICE guideline and the Canadian guideline in particular. And all guidelines contain a management algorithm for eclampsia. Given the rare incidence of eclampsia, given that it complicates about 2.7 per 10,000 maternities in Ireland, the average unit of the Dublin hospitals or Cork where I work, which delivers somewhere between 8 and 9,500 women a year, might only expect to see 2 to 3 cases of eclampsia in any one year. So your lifetime exposure per member of staff is extremely small. There is a complicated mathematical equation that one of my colleagues in the UK worked out, that the average midwife who works on a labour ward in a unit that delivers 8,000 babies a year, on an average 36-hour working shift week may actually work for 42 years before she statistically sees one case of eclampsia. So it's very important that we actually be prepared for eclampsia because it's rare. It's not something we see every day, and if you compare the figures of eclampsia to major obstetric hemorrhage, we can see that. However, it has a very high fatality rate, and it's frequently, as we've already seen, associated with substandard care. So we do need to drill and be aware and on our guard for it. So there's a very basic algorithm which we teach our medical students about: do not leave the patient alone and calling for help. But we'll just talk through the details of this in a little bit more. Women who are fitting need to be placed in a semi-prone position. This is a complicated condition which cannot be managed in isolation. A bit like the major obstetric hemorrhage, eclampsia needs many hands to the deck. And in terms of the professionals who should be involved, clearly the GT obstetric and anaesthetic SPRs who should alert their consultants. It is a guideline, a standard of care in the UK that eclampsia mandates consultant attendance at the bedside, and obviously the most senior midwife available. Airway is very important in anyone who is convulsing or is post-ictal. The airway must be assessed, maintained, and oxygen should be applied. In terms of breathing, the airway, once it's protected, if a woman is not breathing, she needs to be ventilated. Circulation is very important. You saw in the previous slide a few slides ago that there were 3 or 4 cases in the last confidential inquiry of women who had cardiac arrest post-eclamptic convulsion. So again, a high index of suspicion needs to be maintained in women who are convulsing for further collapse, in particular cardiac arrest. And if cardiac arrest occurs, obviously the CPR algorithm needs to be initiated. IV access is critical and should be secured as soon as safely possible because the only drug that is indicated in this particular situation needs to be given intravenously. So controlling seizures. Magnesium sulfate is the drug of choice. No other drug is appropriate. We're now a decade post, or more than a decade post, the collaborative magnesium sulfate trial, which has been repeated in lots of different settings throughout the world and has shown similar findings. So magnesium sulfate is the drug of choice and should be the only drug given for the treatment of seizures and the prevention of further seizures. Drug errors in magnesium sulfate administration are common. When we were writing the guideline, we found a body of literature to suggest that drug errors in magnesium sulfate administration, particularly in the acute setting for eclampsia, occurred in up to 20% of cases. And this is a drug that has a very toxic profile. So to avoid drug prescription measures, our guideline recommends that magnesium should be administered in pre-mixed solutions. These are available. We have them in our labour ward, and I believe most of the Dublin hospitals use them too. They come in 2 different varieties, the loading dose, a 4-gram loading dose, and then a maintenance dose. And yet, despite this, it is still possible to mix up the bags. They don't come very, very well labelled, and we've thought long and hard about colour coding or labelling the magnesium sulfate bags in a more clear way to define in the heat of the moment when we're putting up the loading dose, which is the loading dose and which is the maintenance dose. We mustn't forget that these women invariably have other complications as a result of preeclampsia, and we have to be very watchful for fluid overload. Therefore, all fluids, including magnesium sulfate, need to be given through a volumetric pump, and we mustn't exceed the total hourly intake of 80 ml an hour. Our protocol is quite a dry protocol, and that's deliberately so because women do not die of acute renal failure in preeclampsia, but they can and do die of pulmonary edema. So our protocol is extremely dry. Magnesium sulfate takes up 25 ml of those critical 80 ml, and other fluids need to be reduced consequent upon that. Monitoring of magnesium sulfate. Formal clinical review should occur every 4 hours according to the IMUSE chart, with the additional observations of continuous pulse oximetry, because respiratory depression is one of the first signs of magnesium toxicity. Obviously, hourly urine output for reasons we'll talk about in a minute, and additionally deep tendon reflexes. Deep tendon reflexes will be lost a good bit before women reach respiratory depression. So I can't emphasize enough how important eliciting tendon reflexes are in these women. We actually don't recommend checking magnesium sulfate levels formally with the lab, although we all do it, and I'm as guilty as the next person. However, if we follow the protocol as it's actually written, there is actually no need to formally check magnesium sulfate levels. They should only be checked if the urine output is below 100 mils in 4 hours or less than 25 mils an hour, or if the deep tendon reflexes are lost or ambiguous, or if respiratory depression occurs. 97% of magnesium sulfate is metabolized and excreted by the kidney. So in women who go into anuric acute renal injury failure in preeclampsia, they're at particular risk of magnesium toxicity. And I've certainly had 2 cases of women who have sunk into a magnesium-induced coma because they were anuric, and we were slow to realize that they were not excreting what were actually quite low levels of magnesium. It can accumulate very, very quickly if women are anuric, and these women frequently are, particularly on our protocol, which is quite dry. So we do need to be on our guard for magnesium toxicity. It has a narrow therapeutic range, and you can see here, these are some of the symptoms. Everyone will be aware of the horrible feeling at therapeutic or even just slightly at therapeutic levels of the feeling of warmth and a very unpleasant sensation that women describe of a chest heaviness. It causes massive, quick vasodilatation when it's given IV. And everyone will be aware of women, they complain of feeling very flushed and very anxious, a horrible feeling of someone sitting on their chest. If you don't warn a woman that the drug you're about to give is going to cause that, given that she's critically unwell and people are buzzing around her, she can actually interpret the side effect of the drug as a worsening in her symptoms and be quite alarmed by it. So please do remember to try and warn women when you're about to give them magnesium sulfate that the loading dose can make them feel extremely strange and unwell. But that feeling of warmth is then accompanied by double vision and slurred speech. The next thing is the loss of tendon reflexes, then respiratory depression, then respiratory arrest, and last of all, cardiac arrest. The antidote is calcium gluconate, which should be stocked on every labour ward, and everyone should know where the calcium gluconate is in the event of magnesium toxicity. It's given 10 mils of 10% is given slowly intravenously. Despite the fact it has a narrow therapeutic range, there are very, very few cases of magnesium toxicity resulting in cardiac arrest in the literature. It really is quite rare, although we're all very familiar with it and very aware of how toxic it is. The critical thing for actually reducing morbidity and mortality in this condition is to control the blood pressure. So once magnesium sulfate is on board, we really do need to address again the control of blood pressure. The main aim is to keep the systolic blood pressure at less than 160 millimeters of mercury. There has been historically over many decades an inappropriate emphasis on the diastolic or the mean arterial pressure. These are obviously important, but it's a high uncontrolled systolic blood pressure that breaches the blood-brain barrier and causes stroke. So the main aim of control of hypertension in the immediate term is to actually get the systolic high blood pressure down, the systolic blood pressure down. The aim is to get a blood pressure of around 130 to 140 over 90 to 100. But beware of the undelivered antenatal patient who's still got a baby on board. Reducing the blood pressure, especially in a woman who may already have or has uteroplacental insufficiency and a growth-restricted baby with a very suboptimal placental blood flow, reducing the blood pressure by giving a combination of magnesium sulfate and the drug of your choice to lower blood pressure can frequently result in fetal heart rate abnormalities. It's necessary to actually monitor the baby carefully, but remember that if you do get any sign of fetal distress, these are the very women that we shouldn't be rushing round the corner for a category 1 caesarean section. Our anaesthetic colleagues are rightly very concerned about GA sections in these women and intubation, which can actually cause a quick and sudden elevation in their systolic blood pressure and again be enough to actually blow out a stroke. So everything needs to be done with caution. And certainly monitoring the fetal heart rate is advised, but you need to think very carefully before you act. And if you act, you need to be quite certain about what you're doing. The woman really does need to be stable before being transferred to theatre for delivery. Our guideline uses labetalol as the antihypertensive of first choice. There was a lot of discussion in the group when we were writing the guideline about labetalol versus hydralazine, and we came down on the side of labetalol for a few reasons. The main reason is that it can actually be given orally. So when a woman presents in the day case unit or in the antenatal clinic or in the emergency room, a 200 milligram loading dose of oral labetalol can be on board and will actually reach her circulation within half an hour of administration. Half an hour sounds like quite a long time, but if it's midnight and you're in the ER and you're trying to set up IVs and draw up drugs, half an hour actually goes quite quickly. So the fact that we can give the first dose orally swung it in favour of labetalol. The labetalol infusions that we give per the guideline is neat labetalol, and we give boluses of 10 mils of labetalol, which is in a concentration of 5 milligrams per mil, IV and slowly. And repeat boluses can be given, but if repeat boluses are needed, then clearly an infusion is also required. And again, it should be given via a volumetric syringe driver to avoid fluid overload and to make sure that the accurate dose is given. And it can be doubled every half hour to a maximum of 160 mg per hour until the blood pressure is dropped or stabilised. What to do if the first choice antihypertensive doesn't work is to add in the second choice rather than swap, and our second choice is hydralazine. Everyone will be familiar with the fact that some women just don't respond to labetalol and some women don't respond to hydralazine, and there are in fact about somewhere in the region of about 3% of women who have a genetic polymorphism, which means they cannot actually metabolize hydralazine and therefore will not respond to it. But these drugs should be given cumulatively rather than instead of each other, and then they can be weaned down as appropriate. Hydralazine can really only be given in the acute setting intravenously, and the doses are described here and in full in the guideline. We had a lot of discussion in the guideline, in writing the guideline, about nifedipine. It is commonly given because it can be given sublingually and will work very quickly if it's given in such a fashion. However, there is a profound drug reaction between calcium channel blockade and magnesium channels affected by magnesium sulfate, which can result in a very, very profound hypertension, which may not be particularly harmful to the mum, but can actually be fatal to the fetus if the baby is still on board at the time of the drug reaction. So nifedipine really should be given with extreme caution if a woman is on magnesium sulfate or if you anticipate the need to start magnesium sulfate. It can be a useful third-line drug, but in no circumstances ever should it be given sublingually because its effect is very, very idiosyncratic, especially when it's given in a sublingual fashion. It can cause a very rapid and profound drop in blood pressure, which can be very detrimental to the fetus. And then obviously delivery. Delivery in the setting of someone who's having recurrent eclamptic convulsions or is post-ictal should be very well planned, performed in the best place by the best route and the best support team. And that might sound self-evident, but there are several cases in the confidential inquiry where women died as a result of inappropriate decisions about delivery. So delivery needs to be very well thought through before taking a woman to theatre. And the most critical factor is that the mother needs to be stable before transferring to theatre. And stabilising a mum requires a team effort from obstetricians, from midwives and from anaesthetics, and also our paediatric colleagues. Other points which come out in confidential inquiries time after time are that ergometrin should not be used in the case of severe preeclampsia and eclampsia. The ergot component of ergometrin can cause a sudden and idiosyncratic increase in the systolic blood pressure. So this is one incident where ergometrin should not be used if at all possible, and if it is being used in the face of significant postpartum hemorrhage, it should be used with extreme caution. And these women are also paradoxically at high risk of thromboembolism, and I'm not going to talk too much about that because I think my colleague John Higgins will talk about the complications of trying to judge thromboembolic risk in someone who might have depleted platelets and also might have liver impairments and decreased clotting factors, yet paradoxically is at increased risk of VTE, and how we manage that is important. And finally, just to remember again that it's really important to maintain vigilance as the majority of seizures occur after delivery. Nearly 50% of eclamptic convulsions in most case cohort series occur after delivery, normally when our index of suspicion is lower and our guard is down. Blood tests, according to our guideline, we do all the standard blood tests of serum electrolytes, including a uric acid, liver function test, a full blood count, and a group and save. Clotting is questionable in the presence of a normal platelet count. And before I moved to Ireland, I worked in Manchester, and we had a little student project which showed that we could actually employ an extra midwife for a full 12 months if we stopped doing inappropriate clotting screens on women who had normal platelet counts when they came through the day case unit with query preeclampsia. We spent a lot of money on doing clotting profiles when they're possibly not necessary. However, in the presence of someone who's had eclampsia, it's quite reasonable to take the clotting sample and send it to the lab and ask them to spin it and spin it down, but only run it if the platelet count is low. There's been a lot of talk recently about PLGF, whether PLGF has any role in the acute management of women with fulminating disease. I think before we roll PLGF out across the country and elsewhere, we need a randomized controlled trial to see if it really is as good as some of the cohort studies predict it is. And in the absence of a randomized controlled trial, I strongly believe that we shouldn't be using PLGF in a routine practice for the management of women with eclampsia or preeclampsia. How do we prevent eclampsia? Well, the MAGPIE, the question really does, do women with preeclampsia and their babies benefit from magnesium sulfate? And the MAGPIE Trial Collaborative Group has definitively answered that question with a yes. This showed that there was a 58% reduction in seizure activity, a non-statistically significant, but nevertheless clinically very significant reduction in maternal death of 45%, and a 33% reduction in placental abruption. So mortality and morbidity is reduced massively in women with significant fulminating preeclampsia if they are given prophylactic magnesium sulfate. And obviously I'm not going to talk at length about what magnesium sulfate or the benefits magnesium sulfate has for the preterm baby, but the MAGPIE trial plus others demonstrated that the benefits of magnesium sulfate extend not just to the mother but also to the fetus. So practical skills and drills elements. Eclampsia is rare and it's a complex condition. As we flagged before, with an estimated incidence of 2.7 cases per 10,000 maternities in the UK and about 2 cases per 10,000 maternities in Ireland, each of the busiest 4 hospitals will expect to see somewhere in the region of 2 to 4 cases per annum. I always feel that actually we see more than that, but when I think about it, some of the cases of convulsions we've had in the last 12 months in my hospital weren't eclampsia. And if I think about the eclampsia cases we've had, that's probably about right. So given something that's as rare and yet carries such a high complication rate, high morbidity and mortality, drills are absolutely essential. We urge the use of preeclampsia-specific checklists, team training and communication strategies. I can't emphasize enough how important team communication is in the management of these complex cases. The confidential inquiry flags time after time after time that communication is one of the key areas of weakness in the management of these complex cases. And a continuous process of audit and improvement strategies will reduce hypertensive-related morbidity. And there have been several large-scale studies from Australian hospitals which have shown that drilling for eclampsia and fulminating preeclampsia actually does reduce morbidity. Something that is perhaps less relevant for this audience, but something that I think we should think of as healthcare professionals, is that we actually should be educating our patient cohort. Pregnant women are, as a whole, a very engaged patient cohort. Pregnancy is a teachable moment. These women are, by definition, young. They tend to be early uptakers of disruptive technology, that information hungry, and they seek knowledge about their own pregnancy. And anyone who just steps into our antenatal clinic waiting room and sees women with 5 different pregnancy apps on their phone will appreciate just how information hungry they are. And yet awareness of preeclampsia and its vagueness, how it presents its symptoms and signs, is actually very poor. And Action on Preeclampsia and the Preeclampsia Foundation and all big patient support agencies are currently focusing on targeting the educational level of patients, trying to raise awareness of the signs and symptoms of preeclampsia. And that's certainly something that we can all help with just as part of our routine delivery of antenatal care. One thing that's really helpful is the eclampsia box. Eclampsia box should have everything in it needed to give the first loading dose of magnesium sulfate, cannulas, giving sets, tapes, etc., and clearly marked loading versus maintenance dose of magnesium sulfate. And again, this is a work in progress in our unit, and I'd be interested in what everyone else is doing to distinguish the 2 different bags. But in the heat of the moment, it's very helpful to have some very clearly marked differences between the 2. There are, fortunately, lots of different resources we can use or avail of to improve our drills training. Courses like MOE and now iMOE, prompt, and also high-fidelity simulations are the gold standard, but low-fidelity solutions can save lives too. And I've certainly visited a hospital in a very low-resource setting where they had a very high incidence of eclampsia in Africa, and their low-fidelity solution for treating eclampsia was to actually have the eclampsia drill written on a chalkboard at the end of the ward. It was an eclampsia ward with 10 or 12 beds in it. All the women in there had eclampsia, and they had a chalkboard with the eclampsia drill written in 2 different languages at the end. And they said that one innovation, a chalkboard with the eclampsia drill written on it, had made a massive difference to the speed with which they delivered care to women with convulsions. So, in summary, Fitting or convulsions in the second half of pregnancy is eclampsia until proven otherwise. Eclampsia kills, epilepsy doesn't. There is no harm, epilepsy in that acute setting rarely kills. There is no harm in treating a patient as eclamptic until proven otherwise, as long as all due precaution are taken with the drugs given. Eclampsia is rare, but it carries a very high fatality rate for the mother and for the baby if the baby is still on board. It frequently occurs postpartum when our index of suspicion is down and can occur in the absence of classic symptoms and signs. So a high index of suspicion is needed at all times. Magnesium sulfate unequivocally saves lives, both sides of the placenta, and it should be used. And uncontrolled systolic blood pressure is the leading cause of death. This isn't news, we've known it for 15 years, and yet we seem to be very slow to react to it. So we must not ignore the high systolic blood pressure. Finally, I was asked to include a slide about what to do going back to our units if you could only do one thing, and I could think of more than one thing, and I think there are 3 essential things. So when you return to your unit, do read our guideline. It's about to be revised, and your feedback is absolutely essential. We're actually writing 2 guidelines, management of hypertension in the day case setting, and management of severe hypertensive disorders in pregnancy. Your feedback or contribution to both would be more than welcome. And if anyone's interested in joining the writing group, please do let me know. It's one of those areas where the more the merrier for sure, and we'll get the job done in half the time. If you haven't got an eclampsia box, please construct one, and if you've got one, please check it. And if anyone has any ideas for how to make the labelling within the box more streamlined and efficient, please do let us know. And finally, drill, and drill some more. Eclampsia is rare, it's extremely rare, but it's frightening. It can catch all of us off guard. Even people who research this condition and have a long-standing interest in it can still be caught unawares and can be quite frightened by it. And the more we drill and the more things become routine, the more lives will be saved. Thanks very much.